Hello, this is Dr. William Burke, the director of the Stead Family Memory Center at Banner Alzheimer's Institute in Phoenix, Arizona. I'd like to talk to you about the preclinical Alzheimer's research which is being done at Banner Alzheimer's Institute, as well as other institutions around the country. To begin with, though, I would like to talk to you a little bit about the distinction between Alzheimer's disease and dementia. This is frequently confusing for many people, and it's important to have a good grasp on this distinction. The easiest way to think about this is that Alzheimer's disease is a form of dementia, and dementia is really the umbrella term that includes all types of dementia. I'm going to describe some of the symptoms we use to make a diagnosis of dementia, and then I'll talk about what specific symptoms are associated with Alzheimer's disease. So the basic concept of dementia is that it's an acquired syndrome of decline in memory and other cognitive domains sufficient to affect daily life. And the importance here is that this is acquired, meaning that it's not something that we are born with, and that it is not a trivial problem with memory or other mental abilities, but it's enough that it really impacts day-to-day functioning. Dementia is caused by structural damage to brain systems involved in memory. So this is really a hardware problem if you think about the brain being a computer. It's not a software problem, but it's something wrong with the actual structure of the brain. And Alzheimer's disease is by far the most common disorder causing dementia in late life, in probably 60 to 70% of all of the cases. Of these cognitive difficulties that are associated with Alzheimer's disease, memory is the most famous, but it's not the only one. When we talk about dementia, we're generally talking about impaired ability to both acquire as well as remember new information. So we have to get information into our brain. We call that learning, and then we have to remember what it is that we've learned. Problems with this process show themselves symptomatically as uh, someone repeating themselves frequently, misplacing items such as personal belongings, forgetting events or appointments, getting lost on familiar routes. Other cognitive abilities are also affected, and reasoning and judgment in particular can be seen as problems with impaired reasoning and handling of complex tasks, making bad judgments. We often see this in the context of people not really understanding safety risks, such as around driving or around financial management or being susceptible to solicitors. People may have just generally poor decision-making ability and make decisions that they would not have otherwise. And we also see impacted the ability for people to make multi-step decisions. So, for example, it often happens that we have an increased number of people wanting memory evaluations after kind of the end of the year holidays, where the family all gets together and the mother or father tries to organize a big party, put together a complicated meal, and for the first time really struggles to do that and can't get the food to come out at the right time, can't plan kind of the party like they had before. And so we often see that in that context. People can also have problems with their visual spatial abilities. So being able to see things and make sense of it. For example, people can have problems recognizing faces. They can have problems recognizing common objects. Uh, it is not unusual for uh, people to have problems finding objects that are in direct view, despite the fact that their eyes are perfectly fine. So the vision's okay, that visual information comes into the eyes, it gets into the brain, and then the person just can't really integrate that into what they're seeing. For example, it might be a salt shaker on the table. Their family member asks them to hand them the salt shaker, and they can't see it despite the fact that it's right in front of it, and despite the fact that their vision is tested and is shown to be normal. This can also impact people's ability to operate simple implements or even to orient clothing and have difficulty dressing. Language is very important. Individuals who have dementia oftentimes have difficulty speaking, reading, and writing. Uh, this shows up typically with people who have difficulty thinking of common words while speaking. So they may have what we call word finding difficulty. This often initially is for nouns, and we often test this by asking people to recall all of the words they can think of that are organized by some category, like all the colors you can think of in 60 seconds, all the animals you can think of in 60 seconds. This also shows up in speech with people hesitating as they're trying to speak. This can be due both to difficulty coming up with the word that they want to say. It also can be due to people suddenly blanking out and forgetting what they were going to say. We see this as various speech, spelling, and writing errors. An important change for many people involves personality and motivation. So there are certain types of dementia where change in personality is the initial and most important symptom. We have family members say, I don't recognize who this person is. This is not the person I've been married to for 30 or 40 years. They are doing things that they would never have done before. Uh, Such individuals may be misdiagnosed as having a psychiatric illness, such as bipolar illness or alcoholism, and it really reflects damage typically to the front part of the brain. The flip side of this is that people can have quite profound increases in apathy, so not interested in typical activities. They may lose their drive. They may become socially withdrawn. They may have decreased interest in their prior activities. All in all, this can be a real mystery for families who are trying to understand what's going on to their loved one, because some of those symptoms sound like depression. And so it's very difficult early on at times to understand whether the issue is an episode of depression, whether it's an episode or an evolving dementia. So if you take all those symptoms together, what makes it likely to be Alzheimer's disease? And the abbreviation AD stands for Alzheimer's disease. Well, for people who have Alzheimer's disease, these changes will come on gradually and typically over months to years. We say generally that if you can say what day the dementia started, then it's almost certainly not Alzheimer's disease. So this is gradual and it's progressive. Uh, Patients with Alzheimer's disease have problems with learning, so it's harder for them to learn new information, and it's difficult to recall recently learned information, which we call short-term memory. And it's one of the hallmarks of the illness that short-term memory is affected before longer-term memory. And by that I mean things that were learned, say, in childhood or earlier in life. Very often people have word finding difficulties with Alzheimer's disease, and the combination of word finding difficulties and short-term memory are probably the two most characteristic early symptoms of the disease. People can have all sorts of visual spatial abnormalities with the illness, this difficulty recognizing people, recognizing objects, being able to pay attention to two parts of a visual scene that's in front of them, all can occur. Alzheimer's disease often can affect reasoning, judgment, problem solving, and in some variations of the disease, that can be the primary symptom of the illness. So if that's the symptoms we use in the clinic, what is going on in the brain that underlies these changes? And we'll talk a few minutes about uh, uh, what a neuropathologist might look at if he were looking at the brain. So way back in the early 1900s, Dr. Alzheimer described a single patient. Her picture is here. Her name is Auguste D. And she was the sole patient that Alzheimer's studied of the disease that bears his name. He looked at her brain at the time of death and he drew pictures of what he saw at that time. And these are the pictures here. And if you looked at the brain of a person with Alzheimer's disease now under a modern microscope, you see the same types of things that Alzheimer's saw. So these lesions here correspond to these lesions here, which are called plaques. This lesion here is called a tangle, and it is similar to the lesion you see in panel B at the top. So plaques and tangles are the two most important things that we look for in the brain under the microscope. They are the hallmark of the disease. I'll say more about plaques in a moment, but basically they're accumulations of a protein called amyloid that accumulates outside the nerve cells and we think are very destructive to the brain tissue that surrounds them. Tangles are accumulations of another protein called tau, T-A-U, and this accumulation of protein occurs within the nerve cell, and by accumulating in the nerve cell causes the death of that nerve cell. Now, if you look at the left-hand panel here, you'll see a picture of a brain. This is a brain that has been dissected in a plane, say, between the ears. So the front of the head would be towards you, and back here is the back of the brain. What you see normally is this healthy brain with white matter surrounded by a ribbon of gray matter. And in Alzheimer's disease, you see the brain has shrunken down. The brain shrinks down in a global way, meaning it shrinks everywhere. But in particular, this area here is an area that's particularly important for memory and includes an area of the brain called the hippocampus. You see in this panel that that part of the brain has virtually disappeared due to shrinkage involved in the disease. The hippocampus is particularly important because it is the way station for short-term memory. For us to get something new into our brains, information has to come into the brain, has to be stored in the hippocampus for at least 24 hours before it can be shifted into other parts of the brain to become part of long-term memory. And so when we lose this part of the brain, we have really no way to make new short-term memory. So we have plaques, we have tangles, we have this shrinkage or atrophy of the brain, and along with that we also see evidence of inflammation in the brain, and we see loss of nerve cells and loss of connections between nerve cells. In this cartoon you can see a bit more fanciful depiction of amyloid plaques. This bubblegum-like substance here is an accumulation of amyloid protein, and these plaques again occur outside the nerve cells, and they are associated with damaging the connections between nerve cells and causing problems for the nerve cells in the surrounding areas. Here's another nerve cell which is full of tangles. This nerve cell has died. It has no connections coming off of it, so it's become isolated. When we think about risk factors for Alzheimer's disease, they have an important connection to amyloid, the protein we just talked about. But the most important risk factor overall is age. If we think about 1% of people have Alzheimer's disease at age 60, that number roughly doubles every 5 years after that. So, but by the time people get to be 80 or 85, a third to 50% of people will have evidence of dementia. There are some genetic risk factors that we're taking advantage of in some of these new studies we're about to do. We have a number of very rare mutations in single genes which can cause the disease. And what that means is there's something called familial Alzheimer's disease, makes up just a small percentage of all the cases of people with Alzheimer's disease. But in these families, if you have a specific gene, you will get the disease. And these genes are passed on to 50% of offspring. So if you have a parent with this disease, there's a 50% chance that you will have the disease. I'll say more about this in a moment, but these genes, which are listed here, APP, presenilin 1, and presenilin 2, are all associated with making too much amyloid. People with Down syndrome likewise have brains that contain a great deal of amyloid because the amyloid precursor protein is located on chromosome 21. Patients with Down syndrome have 3 copies of chromosome 21, so they make more of the amyloid than would typically be made. And then there are the majority of cases. So the typical person who has late onset Alzheimer's disease, say people over the age of 60 or 65, we think that this risk comes from a mixture of factors in the environment, and we know of one gene in particular that seems to be associated with a higher risk. All of us have 2 copies of a gene called ApoE. We get one from our mother, one from our father. ApoE comes in 3 variations: ApoE2, ApoE3, and ApoE4. We know that people who have ApoE4 have an increased risk of developing Alzheimer's disease. If you have 1 copy of ApoE4, you have about 3 to 4 times the risk of developing Alzheimer's disease. If you have 2 copies of ApoE4, you have somewhere between a 12 to 20 time risk of developing the disease. If we back up a step and look at a frequent question, people ask us, I have someone in my family who got Alzheimer's disease late in life. Do I have an increased risk of developing the disease? From a very general perspective, there does seem to be an increased risk. Some of that is related to how old your loved one might have been at the time they developed the disease. There's seems to be more of a risk for people who develop the disease in their 60s and 70s compared to somebody who develops the disease in their 80s or 90s. And some of that, again, is that age is a very strong, is the strongest risk factor overall. This ApoE too is associated with an earlier age of onset. So people who get the disease in their 60s and 70s, it may be that that's the risk that's being conveyed to family members. So this amyloid protein accumulates in the brain in Alzheimer's disease. Why do we have too much amyloid protein? Well, these genetic mutations I just mentioned all lead to increased production of amyloid. So we have too much of soluble A beta, which is just the dissolved form of this protein. And then ApoE, as well as some of these other factors, seem to lead to difficulties in getting rid of amyloid. So in some circumstances, it doesn't seem to be too much amyloid is made, but rather we have difficulty getting rid of the amyloid that's present in our body. And amyloid is a normal protein in our body. Once we have too much of this amyloid in the body, this leads to uh, fibrils being made of this protein. Those fibrils come together and stick together, become very sticky, and ultimately turn into these sheets of fibrils, which are almost insoluble. And those in turn end up becoming the plaques in the brain that we see. Those lead to degeneration of the nerve cells. They lead to degeneration of the connections between nerve cells, which we call synapses. In this slide, we look at starting with the gene that produces amyloid. So you have the amyloid precursor protein. From that precursor, you make ultimately these amyloid, first a single fiber, and then groups of fibrils that come together. And then you have a fibril formation, and then the plaque, and then the senile plaque. And the yellow boxes here are things that we have tried and are have tried in the past or are trying right now as ways of interrupting this amyloid pathway. So trying to interfere with its earliest production, trying to interfere with the form of amyloid that accumulates in the brain in Alzheimer's disease, trying to remove amyloid once it's actually present in the brain, trying to keep these fibrils from clumping together. All of those aspects and all of those uh, uh, approaches are currently underway. Well, with that as background, one of the biggest changes uh, in our thinking about Alzheimer's disease has occurred in the last few years, where we typically thought just as Alzheimer's disease is a disease that began and led to a certain clinical course, we began to appreciate that there was a prodromal period, a preliminary period where people had memory problems, but they didn't really have any change in their functional abilities. So they didn't really meet the diagnosis of dementia. What they had was mild cognitive impairment. So they had memory difficulties, but no change in function. And then as we have developed new strategies for looking at the brain and testing people to better evaluate their memories, we have discovered that lo and behold, there's an even earlier part of this illness, which has been referred to as preclinical Alzheimer's disease. And some of the scans that have become available have shown that people with Alzheimer's disease who are at genetic risk for the disease may have amyloid in their brain 15, 20 years before they actually ever develop memory problems. They have other changes in their brain which we can see many years before they actually develop memory problems. And what this has done has opened a window for us potentially to be able to treat people before they ever develop symptoms. And that is the key to this notion of the Alzheimer's Prevention Initiative. So what makes this available to us now is that we have many tools at this point with which we can look at the brain. We have been able to look for quite some time at what's called FDG PET. This says how much glucose is being used in the brain, how much sugar is being used in the brain. There's areas of the brain that I'm outlining on the picture of the brain here, showing this blue area, showing there's certain parts of the brain that don't use sugar very well in people with Alzheimer's disease. Those are the areas that are associated with language and memory. We have other tests now which can show us amyloid in the brain. These yellow areas in this lower quadrant show pictures of the brain where there is an accumulation of amyloid. We can test people to see if they're in one of these higher genetic risk profiles. We can measure the brain and look for any evidence of atrophy in key areas of the brain. We can do special MRI scans to look at how active the brain is. We can measure spinal fluid and be able to measure amyloid and tau in the actual spinal fluid. So we have many better diagnostic tools and research tools than we had 10 years ago. So we have this opportunity to start treatment earlier and to do this now rather than waiting. And the question is, why would we do this now? Because for the first time, we really recognize that there's this preclinical stage of Alzheimer's disease that exists during which silent changes are occurring to the brain. We think that earlier treatment may be more effective treatment and may slow the progression of Alzheimer's disease. We have waited until a person had Alzheimer's disease and many nerve cells have been damaged and lost before we try to treat the illness. And the idea is if we can treat the illness before those nerve cells are damaged, our treatments will be much more effective. We have a series of therapies which we think are targeted and plausible. We have these clinical tools to help us diagnose the disease, and we have this absolute urgent need to provide effective treatment. So the question then becomes, if we're going to try to do these prevention trials, prevention studies, who should we study? And clearly, we'd like to identify people who have the highest risk of developing symptomatic Alzheimer's disease, so we can try to stop that. And so if we looked at our list of risk factors from before, you can see we have some choices. There'd be age, genetic factors, biomarkers, things like Down syndrome, family history. And as it turns out, the key here is to really focus on people who are at high genetic risk to develop the illness. So the plan of the Alzheimer's Prevention Initiative via the Banner Alzheimer's Institute is to accelerate the evaluation of preclinical AD treatments. This has been called a cornerstone in the National Plan to Address Alzheimer's Disease. Scientific American called this one of the 10 world-changing ideas of 2012. And basically, the idea are preclinical Alzheimer's disease trials in cognitively unimpaired people who, because of their age and genetic background, are at high risk of developing symptomatic Alzheimer's disease. In other words, taking people who are cognitively normal, so don't have Alzheimer's disease, but are at high genetic risk to develop the disease because of their genetic risk factors, because of their age. I'm going to talk about a couple of trials here. First of these trials is to look at people who had this early onset rare form of the disease, who have mutations which will lead to the onset of the illness. And the second are people who have two ApoE4 alleles. So they have two copies of this ApoE4 gene, putting them at higher risk of developing the disease. And I'll say a bit about each of those. So the Alzheimer's Prevention Initiative really has three components. These treatment trials, which I'll say something about, biomarker studies where we learn as we go along in terms of these brain imaging studies, spinal fluid studies, MRI studies, looking to learn as much as we can about how to diagnose the disorder using biological specimens. And then a registry where we are trying to build a registry of individuals who are interested in helping us provide an answer to this problem, learning more about the illness, becoming more engaged in trying to treat and prevent Alzheimer's disease. So the first of these studies uh, requires a little trip to South America. So uh, as it turns out, there is a group of families who live in Antioquia, Colombia, South America, where there are a large number of people who have a genetic mutation that causes early onset Alzheimer's disease. We believe that this group of families comes from a common ancestor from Spain, probably in the 1600s. That person came to the New World, began a family. Uh, uh, that family lived in an isolated area. The genetic mutation stayed local to this area, so it has ended up being a tremendous number of affected individuals in a very small area. This is a very unusual group of families. These are persons who get uh, in their mild cognitive impairment around the age of 40. They're in this pre-Alzheimer's disease as young as 35 to 38. They develop a full-blown dementia age 49, and the average age of death is 59. So this kindred exists of about 25 known families who have this common ancestry. There's believed to be about 5,000 of these individuals who are in these extended families, and 1,000 of them, or about 20%, have this gene, which is autosomal dominant, meaning that it is, if you have the gene, you will develop the disease. These people, again, get mild cognitive impairment, this early memory problem around 44 years of age, and develop dementia by the time they're 49. A group of these individuals agreed to help in this first prevention trial. They came from their village to Phoenix at the Banner Alzheimer's Institute, where they participated in a whole series of tests designed to better understand the characteristics of this illness. In front of you, you have a movie which shows over time the depositing of amyloid in the brain in a typical family with this mutation. So these are people who have the mutation, and when I push the button, you'll see a gradual increase in color in the brain. That color represents amyloid accumulating in the brain. So here's age 20, age 25. You start to see the earliest beginning of amyloid accumulation. We're at age 35, more amyloid is accumulating, age 40, and virtually all the amyloid that is going to be deposited has been deposited. So you go from a period where people have no symptoms to the point where people develop the disease. And we'll look at this one more time, and you can see again around the age of 27, 29, the accumulation of amyloid, it continues to accumulate. We're at age 35, and most of the amyloid that is going to accumulate has done so by that age. So in this cohort of families who live in Colombia, they have agreed to participate in an extremely important study looking at trying to treat preclinical Alzheimer's disease. So these are people who don't have Alzheimer's disease. They have a mutation, some of them, And the way the study is designed is that it takes a known group of people, or rather a group of people who have the mutation, and half of them will receive a drug called crenezumab, another half will receive a placebo, and then there's another 100 people who aren't carriers of that gene who will also receive placebo. The way this is set up is so that people do not need to know whether they have the gene or not. And that was the family's request, is that they not know whether they were affected or not. So this trial launched in the fall of 2013, and people will be followed for up to 60 months. They'll receive an injection of this study drug every 2 weeks, and over time they'll be studied repeatedly to see if this intervention is able to stop the development of Alzheimer's disease. That, however, is not the only study. The other study, which is going to start hopefully early next year, which is 2015, is a trial of cognitively unimpaired people based on their age who have this ApoE4 gene are also at risk to develop the disease. So we are going to look for people who have two of these ApoE4 alleles. Two copies of the ApoE4 gene who are at risk for late onset Alzheimer's disease, so typical Alzheimer's disease, and have to be old enough to be close to the estimated age of onset of symptoms. We also have a trial open now called the Tomorrow Study. And I'm going to say a few words about this study, which is up and running and is looking for participants. We're going to change the slides here a bit to talk formally about this. And as we talk about the study, be very careful about what we say about it. So generally, one of the things that some people want to know is, why should they participate in clinical research? Certainly one reason is to have the opportunity to try a new investigational drug. Some people are very motivated by being able to contribute to medical research. People who volunteer in this particular study will really help us uh, potentially help millions of people who are at high risk to develop mild cognitive impairment and ultimately Alzheimer's disease. In the study, you will learn how to measure your cognitive health. We'll look at how age and genetic factors affect people's minds, and people will be very carefully studied during the course of this trial. So the purpose of the Tomorrow Study is really to look at these early stages of Alzheimer's disease before people develop mild cognitive impairment. It's going to be a large study, 5,000 people, North America, Europe, Australia. The purpose really is twofold. So two goals here. One is we're trying to develop a better test to see if we can predict who is most likely to develop mild cognitive impairment due to Alzheimer's disease. And the three factors that go into that test will be a person's ApoE4 gene, another gene called TOM40, which we think is very important for mitochondria, which are the energy packets of the cells. So there's evidence that in this disease that the mitochondria, which are extremely important for normal generation of energy processes within every cell in the body, that mitochondria become leaky and quit functioning as effectively as they normally would. And for that reason, have been identified as a potential risk factor. And then age, as I mentioned earlier. So we're going to explore the safety and effectiveness of a study medicine in trying to delay these first symptoms of mild cognitive impairment due to Alzheimer's disease. And again, what is this mild cognitive impairment due to Alzheimer's disease? This is that phase before a person has Alzheimer's disease. It's marked by this gradual progressive decline in thinking, but not a change in function. So it's significant, but it's not enough that it interferes with daily life or the ability to function independently. Who can participate in this trial? You may be able to participate if you're 65 to 83, if you're in good physical health and mental health, if you don't have a current diagnosis of a mental illness, and have a project partner, someone who's willing to come and kind of help us uh, 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 learn about you. Uh, so from a perspective of participation, people who have cognitive impairment are not eligible. People who have dementia are not eligible for this study. People who have other neurologic problems, say Parkinson's disease, those sorts of conditions, psychiatric problems are also not able to participate. And then any other diagnosis that might interfere with your cognitive performance so that you already have established memory difficulties. An important part of this study is a project partner who's willing to come with you. Uh, the partner's job is to provide us information about uh, the participants' thinking abilities and behavior. They attend the regular study visits, and it helps us track over time whether a person is developing any of these early memory difficulties that we're trying to detect. So how does this study work? There's really three phases of it. The screening period involves a study doctor talking to you, doing a medical history and a physical examination. A blood test will be drawn that will look at specific genes, and if the person fits the profile at that point, then they might be invited to the next stage, which is receiving this investigational medication or alternatively a placebo, which looks just like the study medicine, except it doesn't have any active ingredients, and sometimes we call that a sugar pill. The person who participates along with their partner come to a study site every 6 months. They also answer some questions on the telephone every 3 months between those visits. We believe that this trial will take about 5 years to complete. That number is really based on guessing how long it will take to have a certain number of people develop this MCI due to AD. And then at the end of the study, you'll receive a physical exam and other tests, as well as a follow-up calls 2 weeks after the study's completed. So if you're interested in learning more about the Tomorrow Study, here's a web page which you can go to. This is a extraordinarily important study and would be delighted uh, to have your participation. Thank you very much. This is Dr. William Burke from the Banner Alzheimer's Institute.